Well, I mean, we don't necessarily always have everything work out exactly as we plan it, do we, in life? But it's a real pleasure to be here with you today. My name's Jeff Scholten, and I'm currently the president of NUCA. I also teach at Life West, and so a bunch of the people that I taught last quarter who got through the class graduated. Hopefully none of you, well, what should I say there? I guess I'm looking forward to next semester when I'm back again to see the next group of 13th and 14th quarter students, or 11th and 12th quarter students, where we talk about diagnosis and management of spinal disorders. But my topic is the upper neck. And I was asked to come here and chat a little bit with you about the craniocervical junction. And so when we talk about salutogenesis, and we talk about the difference between what chiropractors do relative to trying to promote health and pathogenesis, the sort of study of disease processes, it really sort of starts to change how we look at it. And chiropractic is really uniquely positioned to support people as they try to be as healthy as they can be. I mean, we're at a time right now where the first person who's supposed to live till they're 140 has been born. The question is, what's the quality of that life going to be like? And so this picture is of my daughters a couple of years ago and my sister. My sister Kristen is somebody who worked at Life West. She loved chiropractic. She introduced me to chiropractic. At age 2, she was diagnosed with a foraminal valley, patent foraminal valley, so a hole in her heart, and she had to have a surgery. Now, my understanding is these days it's very different than what it was 40 years ago. But at that time, it was a very major surgery for a 3-year-old to have, and that's what she had. When she was 5, she had a stroke, and that stroke left her hemiparetic. So one side of her body didn't work properly. There was an upper motor neuron lesion. And so it was in spasm. And so for her life, she existed in a state of, I guess, challenged health is kind of maybe a bit of an understatement. But what was interesting about that is growing up, we were really acutely aware of our own mortality. We had a sister, my brother and I, who we were told that she was supposed to live until she was 18 years old, max, right? That was sort of her timeline. So growing up, it kind of changes how you understand your life and other people's lives. You know, when you see the challenges that somebody in your own family has. Now, she passed away last year, and she made it to 40. And the question is, how did she do that? You know, my parents are both psychologists, so I've been tested a lot. But my parents, who are both psychologists, really, there's a marriage of pathogenic intervention and salutogenic intervention that was necessary to create a situation where somebody with a sentence of 18 years made it to 40. And when she went out, by the way, she didn't go out because of her disease process. She went out, and again, none of us get out of it alive, do we? But we don't necessarily get to choose how we go out. And for her, she ended up getting her undergraduate degree, ended up getting her master's degree, and what happened with her is she fell, and because she didn't have the left side of her body working, she hit her head really hard, and within a minute was unconscious and passed away fairly quickly. So there's a bit of mercy in that, right? To a certain extent, it was a little shocking as well, but there's a bit of mercy in that. But that marriage of pathogenesis and salutogenesis, the idea that there are actually things that are going on here pathologically that maybe need intervention on one hand, and then how do we also support optimized health? And so my parents, when she was 16, my parents found an upper cervical chiropractor. She had been going to chiropractors for pretty much her whole life. My grandma told me stories of going to a chiropractor. In fact, my grandma had a rib broken by a chiropractor, sued the chiropractor, and continued to see him. She said, well, he messed up, you know? Doesn't make him a bad guy. He's a great chiropractor, but he broke my rib, so he should pay. So talk about locus of control, right? One of the concepts of salutogenesis, and again, these are my two children, and one of the number one things that I want as a parent to be able to facilitate in my children is self-efficacy, right? The ability that you know that you can get done what you need to get done, right? And that's the locus of control concept, this concept of when you have a bad grade on a test, was the prof out to get you, or did you just not study enough, right? If you have a great grade on the test, was the prof made a mistake and made it too easily, or did the test too easy? Or did you do what you needed to do? Is it in your control, or is it in somebody else's control? And so, in chiropractic, one of the challenges that we have is we're regularly talking about the miracle of chiropractic. Has anybody in this room experienced a miracle relative to chiropractic, what they would consider to be a miracle? Let's see. What do we have? Anybody have a left arm in this room? Who has a right arm in this room? Okay. So the lights are a little bright, so I can't quite get a sense of this, but you know, when you go to chiropractic college, so for me, I went to chiropractic college because I was doing my undergrad in kinesiology. My sister had a 60-degree scoliosis. She had a pelvis that was distorted. My parents flew her to a chiropractor to go get adjusted, and he leveled her 1.5-inch leg length discrepancy. He leveled her pelvis. He did all of this to the structure. And I thought, wow, how does that work? That's interesting. And then my girlfriend at the time, who's now my wife and has been since 97, so this is back probably around 96 when I'm thinking about going into chiropractic college. She says, well, if you're gonna go, I better go and try it. Now, her family had a story about chiropractors that her grandfather had his neck broken by a chiropractor. So nobody in that family went to chiropractors. So she went in and she said, well, I'll give it a try, see what it is. Now she had a bronchitis when she was 18 that was treated with antibiotics, and she kept going into walk-in clinics and kept getting antibiotics. And a year down the road after doing this, she went into a physician who was new, took a detailed case history of her and said, you don't need more antibiotics. You actually need to stop antibiotics. And so, but what she was left with was a pretty severe asthma. And when she went in to get her neck adjusted, she got it adjusted. She didn't really have a lot of complaints. She was crooked and she got balanced, but her nose started running. And her nose ran for 3 days, and her asthma was done. And what's interesting about that, and this is really from a salutogenic concept as well, after she could breathe, she could take a deep breath, she could exercise again without bronchodilating, you know, all of this stuff changed for her. But what she said was that she recognized with her new lung capacity that she had always had some level of restriction even before this bronchitis came on. Like she could never breathe as deeply even before as she could after she got adjusted. We're at a time right now where some of our colleagues are trying to say, we really need to just limit chiropractic to neck and back pain. But there was a time when we didn't have any evidence about our effectiveness on neck and back pain either, you know? So what we need to do is we need to understand that we're not treating neck or back pain. We have patients with neck or back pain. They're coming in. We need to understand them. We need to classify them. We need to be able to communicate. We need to do our due diligence. But what we really have to do is deliver excellent chiropractic care. Because if we can do that, the bodies tend to take care of themselves. And so when we're thinking about the locus of control again, we're thinking about who's in charge of this. So when you're a student and you're in school, there's a lot of things that are going on, but you're in charge of your perception, you're in charge of your relationship there. When you're a doctor out in practice, there's a lot of forces that are at play, and you get to interpret them yourself. And there's believe it or not, I'm Canadian, you might hear it in the accent a little bit, but there is a Canadian astronaut. Actually, there's more than one. But one of them, David Hadfield, he said, as a fighter pilot, it's more important not to know what to pay attention to, but to know what to ignore. And so a lot of our lives, we need to know what to pay attention to. It's very important. But we also have to know what to ignore. And that comes from our own internal understanding of our own ability to interface in the world and make a difference for the world, and that confidence that we need to have when we go out into the world. There's a particular piece that I want to share with everybody relative to technique. If we look at this slide and we see perhaps there's no socks here, the question is, where do you put the socks? Right? So socks and shoes both work, but there's a particular order that works better, right? And so as we're trying to figure out, so my focus is the upper neck. Now, here's what you need to understand about me. I don't focus on the upper neck because I believe that it's the only thing that needs intervening with. I focus on the upper neck because I think it's a critical and crucial area, a vital area to human health that deserves a dedicated practitioner. So that's me, right? But I refer out to other chiropractors. I get referrals from other chiropractors. We refer to other practitioners. We get referrals from other practitioners. And so to understand how to intervene with those people and how to interface with those people is a really important thing. So in this situation, what you have to understand is that as you're looking at the body, maybe you've heard of this, maybe you haven't, but this is one piece I want to leave with you. There are ascending and there are descending issues going on in the body. I know we're talking above, down, inside, out, but that's not really what I'm talking about here. I'm talking more ascending or descending. So for instance, if I have a pronated right foot and it causes my pelvis to twist like this and my knee to track medially, then maybe if I do that, I'll get a valgus stress in my big toe, it gets stiff, right? And there's structural change that's associated with that. Dan Murphy this morning did a great job kind of explaining what happens fibrotically with structural change over time. But what happens when you're intervening with a patient and they have a pronated right foot, but their pelvis is twisted back on the right, and you're trying to get their pelvis untwisted? Is it possible that might create an increased strain in their hip, their knee, or their ankle? So our job is to sort of, even though I'm intervening in this area only, I'm assessing the entire body. My initial assessment has people tracking their knees to see how that's working, checking the pronation, okay? We also check the bite. So when you have somebody with right head tilt, as an example, if their teeth are hitting prematurely on the right, that's called an ascending issue. So the head tilt is creating the bite imbalance possibly. A descending issue would be a head tilt on the right with right premature contact. So when you bring the head tilt out, that can increase, potentially, not always, but it can increase the occlusal imbalance. So as chiropractors, when we're dealing with salutogenesis and pathogenesis, we have to recognize that they're on a continuum, but that we can, through our interventions, sometimes mess up what was a comfortable compensation in a certain area. And so the more we can understand that, the better. So in our assessment, for instance, we check eye level. So it's an easy thing to check if you can see vertical, if you can see horizontal as horizontal. So if you hold your thumb out, and you tilt your head, and you look into the distance, you'll see two thumbs if both eyes are working well. And as you tilt your head, you'll see them unbalanced. And so you can check with your patients. Do you see level as level? Where do those thumbs look level? And if they say, well, I see level over here, then you have to integrate with an optometrist. If you have somebody bite and you see head tilt and it's opposite head tilt, you have to integrate with your dentist. If you see the arches dropped and the hips are shifted, you have to integrate with somebody who's dealing with the feet. For me, it's a podorthist. Okay? So we all have different pieces. And the socks or shoes concept, like what order does this go on? So if you're going to deal with the upper neck and the teeth, you got to make sure the upper neck's in an appropriate position before you balance the teeth. So we don't exist as a profession in isolation. And when I taught my class, it was called Diagnosis and Management of Spinal Disorders. And for me, that meant that we need to classify our patients, right? So we got to classify them somehow. And then we need to do what we do. And then when what we do doesn't do everything that patient needs, which is pretty much most people that I see, right? The average person I see has 10 or 11 chief complaints. So there's going to be some things that are responding, some things that aren't, some things that are partially. Then the management side is figuring out how do I draw that person through a process, okay? And so that's the piece relative to technique. This is a big audience. We're not going to sort of get into how to draw an atlas plane line and how to do a NUCA analysis or how to do the Blair analysis or how the underlap or overlap goes. But hopefully everybody in this audience can take a little bit home from that. Because there is a hierarchy of neurology. Now this is just, I got to get a little bit, since I kind of feel like I'm on a bit of a soapbox here, I guess I can get on it. There is a hierarchy of neurology. You know, when you catastrophically fracture your low back, you're a paraplegic. When you catastrophically fracture your neck, you're a quadriplegic. So by all standards and definitions, a neck injury of the same magnitude as a low back injury is worse. So if you injure your upper neck that much, you're dead. It's time out, like you're finished, right? That was your exit, okay? But what we can understand is if people have injured their upper neck, but they're not dead, they're on a continuum. So it can't be normal anymore, but they're on a continuum. We really want to move them towards that area where their body can comfortably compensate. So the upper neck is a really critical area. It's not just another bone. It's an area that you have to pay a lot of attention to. And there's a lot of ways to pay attention to it. But when a baby's born like this, you know, we've got vital signs, but what's the quality of the life that this baby is going to lead? There's an entire country that has now, and continent, I guess, that is stopping chiropractors from seeing babies. But the problem is, and Heiner Biederman wrote a great text on this, is that he says, ignore the kids. Okay, now he's a physician in Dusseldorf, or Cologne, sorry. But he says, ignore the kids, ignore the adults, because everything's locked in, right? It's the kids who have the ability, to make morphological changes. So why is that? Because babies aren't born with their bones fully intact, right? It's cartilaginous or membranous bone that the bone comes in. If you know, as a child, you have quite horizontal occipital condyles. As an adult, they become more vertical, okay, from a frontal perspective. So how does that happen? Well, what happens actually is that the condyle is already there. You just can't see it on the x-ray properly, but it grows into the lateral mass of the atlas as it ossifies. So it's not that the cartilage is already there. It is already like this. It's just not bone yet. You can't see it on an x-ray or on imaging. So what are we going to do for these kids? So when you're looking at the upper neck, it's an area because of this hierarchy of neurology that demands a level of specificity to get optimized results. So when I was introduced, we talked about us all as a profession recognizing that we have a similar way of looking at the body, and that multiple people can be right, without somebody being wrong when you're sub-truth, right? Does that make sense? So we need to work with each other. We need to be using each other's expertise. We also need to be working with the other professionals. The other professionals out there are not out to get us. They literally, there might be some pieces that people don't have any interest in understanding, but the majority of them are just trying to take care of patients. They just are lacking information, okay? And we have to be ready to allow them that growth process, that understanding process. My first dental conference in 2002, I was introduced to a chiropractor from Calgary, and he said, "How does it feel to never treat the cause of anybody's anything?" I said, "Hi, Dr. Westerson, Dr. Scholten, nice to meet you. How does it feel to never treat the cause of anybody's anything?" he said. And so I could have just stormed off and yelled at him and said, "Dentists are asses," and that's it. But I said, "That's interesting perspective, explain yourself." And he did, and it made a lot of sense. I won't get into it now, but it made sense. And so when he was able to explain himself, then he allowed me to explain myself, okay? And so let's dig into the upper neck for a second. What do we see here? Does anybody see anything that's an issue with these images? Let's take a look at that. Like, what's there? What are you noticing? What are you concerned about? I mean, we're not having a real conversation in this size group, but I want you to just think to yourself, like, when you see this, what are you seeing? You see images, but what's inside there? So Dr. Rosa, who's one of my mentors, will do a great job, I'm sure, taking you through MRIs later this weekend. But right here are cerebellar tonsils. Right? There's a relationship here with what's called the clivus, which is made up of the sphenoid and the occiput, and the odontoid peg, and that's called the clivaxial angle. That looks like this. And this angle needs to be somewhere between 150 to 165 degrees. And if it's less than that, if it's more acute, then it creates anterior compression to the brainstem. And as you flex and extend, it changes the amount. So if you've never heard of the clivaxial angle, that's something that some of your difficult migraine patients, they have this structural problem. And if you don't know about it, to look for it, hopefully this changes a little bit, you can start looking for it. You can take imaging, CT imaging, like what I showed you there. X-ray imaging, you can start to see it, but CT, it's a lot easier. What about this piece right here? What's there? What goes through there? What goes through here? And what's happening in this person with that relationship between the posterior tubercle and the inferior aspect of the occiput and the superior aspect of C2? We've got myodural bridges, right? We've got the rectus capitis posticus major, the inferior oblique. Those are type 1 collagen that's going through that area that's holding the space open, the subarachnoid space, so that fluid can flow and nourish, right? We have to understand that. What does this area deal with? This piece. Did everybody pick this up? The periodontoid space? What are we worried about there? I mean, these are the strong ones, the alars and the transverse atlantals, but there's the transverse occipitals, there's barcals, there's the apicals, there's all sorts of other ones that would have already torn before that could move like that. And so this is a 9-year-old girl, so what is her future like when you look at these pieces? And then if we look at a post image a couple of months later, what does that look like to you? What's the difference here? What's the difference here? You see that? So we want to change these things and change people's ability. This is how you can look at some images. I don't know if you have this technology in your office, but we sure love it. To be able to look at these complex cases, whether through CT like this, whether through MR. So the real question here is, how are we going to break through? How are we going to, as a profession, come together, work with each other, figure out what each other do? I don't have time to teach you all of this. I have many hours of instruction that we could do. I did 24 for the diplomates on upper cervical anatomy. So it's like, this stuff we have to study. You might not have interest in this to dive as deep as we have, but you know that we exist to help you. And I might not have interest in exactly what you're doing for myself to do it, but I need to understand it well enough to recognize when a referral is appropriate so that we can work together, whether inside the profession or outside of the profession. And we need all of us, it's kind of an all hands on deck time right now. Whether you're a student in the school or whether you're a clinician in your office, the time, treasure, and talent that you can contribute back to your profession, your alma mater, your organizations, your associations, we need everybody working. We don't need to have just one of a group. We need the group with the one lone person who isn't working. So I really appreciate you having me here today. Thank you very much.